Very good morning, everyone. Welcome to Indian Society of Gastroenterology Masterclass. As you know, this is the 16th in the series. In the last masterclass, we had a wonderful talk by Dr. A.S. Puri, and he spoke on how do you diagnose and manage a patient where you find NET. And we all agree that his talk was absolutely fantastic. For those people who are joining for the first time this masterclass, we have kept all these lectures, which have been wonderful so far, and into ISG library, and you can access at any point of time. But today we have again one very important clinically relevant topic, that is alcoholic hepatitis. How do you diagnose and how do you manage? We know that there are a lot of controversies in treating alcoholic hepatitis. And to address all those tricky issues in clinical medicine while treating alcoholic hepatitis, we had a very renowned person and a renowned hepatologist, Dr. Kaushal Madan. Dr. Kaushal Madan is a director of gastroenterology at Max Super Specialty Hospital in New Delhi. He has been a very proud alumnus of AIMS New Delhi. We all are so proud of Dr. Madan that he did so well while he was being trained at AIMS and later on. So welcome Dr. Kaushal Madan for this talk.
Thank you, sir.
And to moderate the session, we have another renowned person, Dr. Sandeep Nijhawan, who is head of gastroenterology at SMS Jaipur, and again, very well renowned and a great teacher. So welcome Dr. Nijhawan to Masterclass. To further on, I may request Dr. Saraswat to address, and then we go to talk by Dr. Madan. Dr. Saraswat, sir.
Thank you, Dr. Govind. Good morning, friends, ladies and gentlemen. Always a pleasure to welcome you to these ISG master classes. As Dr. Govind has told you, this is the 16th class in the session that we began in mid-April, about 16th of April. And the overall response we have had to these classes has been so encouraging that we are continuing with this series, although albeit just on a weekly basis now on every Sunday. And for today's session, the topic of alcoholic hepatitis is very topical, pertinent. In fact, there was a time when alcohol was constituted all of hepatology. Everything in liver disease and hepatology around for so long. Nevertheless, I think understanding, insights, and therapies for alcoholic hepatitis are still evolving, and particularly in the subset of people with severe alcoholic hepatitis. Alcohol, as you know, is probably the commonest cause of liver disease in most parts of the world. Certainly in most parts of India, that is the case. And the severe alcoholic hepatitis continues to be a situation where there are very few solutions, and we really look forward to hearing the views of Dr. Kaushal Madan on this. As you all know, Kaushal has been one of the very bright products of the AB2 ward at the All India Institute. He is presently, apart from heading the hepatology group at the Max hospitals, is also the Secretary General of the Indian National Association for the Study of the Liver. And he is one of those speakers whose talks are always lucid, crisp, and to the point, updated, packed with information, and always an enjoyable to listen and learn from him. With these few words, I will invite Dr. Kaushal Madan to talk about alcoholic hepatitis to the audience. Kaushal?
Yeah. I'll just share my screen. Just a second. So is my screen visible?
Yes.
Yeah. So let me start by thanking the ISG, Dr. Saraswat, Dr. Govind, for making me part of this prestigious ISG masterclass. So I've been asked to speak on stepwise management of alcoholic hepatitis. So those of us who've been managing such patients do realize that it's a very frustrating affair, very frustrating experience of managing these patients and making them live beyond a certain time. And the fact, as was given the introduction by Dr. Saraswat and Dr. Govind, that it's mired in lots of controversies, the management part, because there is no definite treatment. That's why sometimes it's very confusing to go down a certain path when you are managing such patients. So let me just reiterate the pathogenesis, because in the times to come, the understanding of this pathogenesis, we will be able to develop newer modalities of management. So the alcohol causes liver injury by two means. One is by direct injury by alcohol or its metabolites, or by indirect injury by way of recruitment of immunoinflammatory system, supported in this effort by the microbiota and the leaky gut, which again is a product of alcohol abuse or excessive alcohol intake. The direct toxicity in the liver is secondary to oxidative stress and endoplasmic reticulum stress. We all know the major driver of oxidative stress in alcohol-induced injury is normally the alcohol is converted to acetaldehyde by the alcohol dehydrogenase enzyme. Due to excessive alcohol intake, this pathway is overwhelmed, and then the ethanol is getting converted to acetaldehyde by cytochrome P450 2E1. This particular conversion leads to generation of free oxygen radicals, causing lipid peroxidation and hepatocyte injury, and further leading to propagation of inflammation in the liver. So in short, if I have to describe, alcohol, by causing oxidative stress and ER stress, leads to hepatocyte injury. The damaged hepatocytes released extracellular vesicles or damage-associated molecular patterns. On the other hand, alcohol acts on the microbiota, causes a leaky gut, causes the pathogens and their products to leak into the portal circulation. These are called pathogen-associated molecular patterns. These, along with DAMPs, act via the toll-like receptors and nod-like receptors on the hepatocyte, on the liver Kupffer cells. These lead to production of inflammatory cytokines, which attract more inflammatory molecules and inflammatory cells, and together they lead to amplification of inflammatory response and injury, and a self-propagating inflammatory state is set into place, which leads to significant liver damage and liver failure also. And the major cytokines which are responsible for this mediation are usually TNF-alpha, IL-1, IL-6. So let's come to the major issue, the main part of the talk, which is the management. If we talk about the stepwise management, let's look at what is the step one. Step one is when the patient comes to you and you're asked to make a diagnosis of alcoholic hepatitis. So can you make a positive diagnosis clinically? Answer is yes. So these are the National Institute of Alcohol Abuse and Alcoholism criteria for making a diagnosis of alcoholic hepatitis. So alcohol intake of more than 60 grams per day for men or more than 40 grams per day for women for more than 6 months and less than 60 days of abstinence. It's not like when the patient presents to you with jaundice, he should be drinking till the last day. So even if the patient has been intermittently taking in last 60 days, but had been regularly taking in last 6 months, then also you can consider this as having alcoholic hepatitis. The raised AST, ALT are usually less than 400 international units per liter, and the usual AST, ALT ratio is more than 1.5. The classical description earlier used to be more than 2. The bilirubin should be more than 3, and very importantly, you should be able to exclude other causes of liver disease. And when that's not possible, liver biopsy is the gold standard, but the problem is it's rarely done because of its invasive nature. And in most cases, in fact, almost 95 to 99% of cases, the coagulopathy, which is associated with disease, precludes its use. And when you are able to do it, the findings you get is neutrophilic infiltration, steatosis, Mallory-Denk bodies, and ballooning degeneration, with or without chicken wire fibrosis. However, in most cases in our clinical practice also, we resort to the use of liver biopsy mainly to rule out other diagnoses if you are suspecting another diagnosis. So possibly when the patient is hiding the intake of alcohol and you are strongly suspecting alcohol intake, that is the time when you can do a biopsy. Or you are suspecting that the patient might be having other causes of liver injury, for example, drug-induced liver injury or autoimmune hepatitis, then you may want to resort to a liver biopsy. The step two, I think in order to go further, in order to treat your patient, it's very important to assess the severity. It gives you the prognosis of the patient and it gives you an idea how aggressive you want to be in its therapy. So there are a number of parameters and a number of scores, and I would say scores of scores which have been described for assessing severity. However, the most frequent and the most validated scores are the MADRS discriminant function. Even after so many decades, I think we are still using MADRS discriminant function, and it is a simple bedside tool. And in 2 minutes, you are able to gauge whether a patient has severe alcoholic hepatitis or not. The second one is the MELD score. We are all familiar with it. And those of you who find it difficult to just enter the values in an online calculator, in fact, most of us do it that way, and you get the reading. And the cutoffs described for severe hepatitis are, for MADRS, it's more than 32, and for MELD, it's more than equal to 21. So the classical description of MADRS score, if it's more than 32, most, I would say about 50% mortality at 1 month. That was the classical description. However, there is also now an understanding that patients who have very high MADRS more than 54 or 55, these are the patients who doing anything medically is possibly going to be futile for these patients. The third important step, although you would want me to talk about it later, but I think it's at this level that we must do it, and this has never been talked about. The step 3 is to differentiate severe alcoholic hepatitis from alcoholic ACLF, something which is not usually talked about, and I'll tell you later why. So ACLF is defined as acute hepatic insult manifesting as jaundice with bilirubin more than 5 and coagulopathy, complicated within 4 weeks of onset of jaundice by ascites and or encephalopathy in a patient in whom you knew that patient had underlying CLD, or now you have found the patient has a chronic liver disease and is associated with a high mortality. So this was the definition given by Apasal. And why is it important? Because ACLF with or without a number of organ failures is associated with a very high mortality. So if ACLF patients have 3 organ failures, the mortality is as high as 80% at 3 months and almost 75% at 1 month. This was the data from the INASL consortium of more than 1,000 patients, again suggesting as the number of organ failures increase in ACLF, so does the mortality, with a median mortality of almost 45% at 6 months. And in this particular study, again, you can see that the causes of acute and chronic liver failure, if it is alcohol, it is associated with a very dismal survival. As you can see, the curve of alcohol is the lowest. Why I talked about it and why it is important to have this step here, I'll talk about later when we talk about management. But how do we differentiate? See, clinically, many of these patients will have jaundice, they will have ascites, they will have encephalopathy. Many of them will have features of portal hypertension also. If you do an endoscopy, you might find early varices. But does that mean they have got an underlying cirrhosis which has led to this? No. Even in acute alcoholic hepatitis, you may get all these features. So how do you differentiate? And again, I will emphasize, why do we differentiate? Get a CT abdomen done, get an abdominal scanning. If you have a large liver with minimal ascites or minimal signs of portal hypertension, this is possibly severe acute alcoholic hepatitis, which is being shown on the left, and there will be a large congested fatty liver. If you have a liver like this with significant ascites, shrunken small liver, and with features of advanced portal hypertension with multiple collaterals around the stomach and the G junction, then possibly it is a typical alcoholic ACLF. You have to handle these two groups separately and differently. Then comes the next step, how to manage these patients. Step 4, that is treatment, after you have decided whether you are dealing with a mild to moderate disease or a severe disease. So in mild to moderate disease, all you have to do is supportive treatment, nutrition, replenish the macronutrients, treat the patient symptomatically. The specific treatment will further depend on severity. Let's talk about nutrition. A couple of slides. You want to make sure that patient eats, give them antiemetics if they are having nausea, vomiting, replenish their macronutrients, specifically thiamine and vitamin B12. These are found to be deficient in most of these patients. The recommendations for replenishing macronutrients are that since most of these assays are frequently not available, usually not available, so it's better to empirically replenish them. That is what the recommendations are, SPEN as well as INASL guidelines when you deal with patients with nutrient deficiencies and chronic liver disease. They should be given high calorie diet, at least 35 to 40 kilocalories per day, and a high protein 1.2 to 1.5 gram per kg per day. I'll just talk about this particular trial. It was a European multicentral trial which included 136 alcoholic hepatitis patients, in which they gave intensive tube-based enteral nutrition versus conventional feeding in addition to steroids. And they found no difference in mortality. So aggressive tube feeding, in fact, 3 of these patients had aspiration and 1 of them died. So aggressive tube feeding may not be advisable in these patients. However, do remember that these patients need significant calories. And in this study itself, they demonstrated that irrespective of how they were given calories, those patients who were given calories less than 21.5 kilocalories per day had a higher mortality than those who received higher calories, 65% mortality versus 33% mortality. The third important point, whether it is acute or whether it is a mild or severe disease, is to stop drinking. So it's never too late to stop drinking. Many patients would come to you and say, Dr. Saab, it's already too late. What will happen if I stop drinking? So this was a study which suggested that whatever stage you are in a patient with alcoholic liver disease, abstinence always leads to long-term better survival as compared to those patients who are either intermittently drinking or continuously drinking. And not only severe disease, this is a recent study of 121 patients with alcoholic hepatitis with mild disease, that is MDF less than 32. 30% of these patients remain abstinent. Those who were abstinent had a higher 5-year survival as compared to those who were not abstinent, even in the low MDF group. So even in low MDF group, the short-term mortality may be low, but if they continue to drink, their long-term mortality will be high. So how do you maintain abstinence? So these are the drugs which are available: acamprosate, naltrexone, nalmefene, and baclofen. We as gastroenterologists are very well versed in using baclofen. The psychiatrists use acamprosate, and there was a randomized control trial in 84 alcoholic cirrhotics in which 12 weeks of use of baclofen was associated with better abstinent rate as compared to placebo. So coming to the the step 3 of treatment of managing severe disease, the issue of corticosteroids. And as you can see, a disease which has, and a drug in a particular disease which has so many randomized control trial, and look at the list of meta-analysis. So obviously it is not a gold standard therapy. If you have to do so many meta-analysis to find out whether a drug is efficacious or not, obviously it is not that efficacious. So 5 meta-analysis, survival advantage, yes, no, yes, no, yes. So it's very obvious, but I'll point out this particular meta-analysis which helped us in selecting patients who would be benefited from steroids. So they included patients who had encephalopathy. All of these trials suggested there was a improvement in survival, but only when they excluded patients who had GI bleed. So if you have GI bleed patients, they are not the right candidates for steroid therapy. So is there another indicator to guide which patients on steroids are going to be responders? Again, the answer is yes. The answer is with this Lilly model. This model was tested in a cohort of 320 patients. Very simple parameters, 6 parameters: age, renal insufficiency, albumin, bilirubin, and evolution of bilirubin at day 7. And with a cutoff of 0.45, those who had a Lilly score of more than 0.45 had a very dismal survival. So if you are giving steroids, measure the Lilly score at day 7, then decide whether you want to continue steroids or not. And when this model was compared with MDF, CTP scores, MELD score, or Glasgow score, this scored best over all these models. And its importance was also exemplified in this particular meta-analysis by Mathurin et al., which showed that patients treated in the corticosteroid group had a significantly better survival than those who were not treated with corticosteroid. And this benefit depended heavily on the Lilly score. They divided patients into those who were complete responders if their Lilly score was less than 0.16, partial responder 0.16 to 0.56, and null responder if it was more than 0.56. So there was a dose-response relationship. So if your Lilly score was more than 0.56, these were the patients, if you continued on steroids, they were going to get complications and possibly die. Now the issue of giving corticosteroids and be scared of getting infection. So how do we tackle that? So this was a study, 246 patients with severe alcoholic hepatitis. After starting steroids, 56 developed infectious complications. And it was seen that only those who were non-responders by Lilly score were the ones who were likely to develop infection. Again, suggesting if you continue steroids beyond 7 days in Lilly non-responders, you are likely to cause infection and likely to cause mortality. Second drug which has been debated a lot is pentoxifylline, which has an anti-TNF action and also suppresses other cytokines. And in an initial study published in Gastroenterology, 1200 milligram of pentoxifylline versus placebo, the 1-month mortality was significantly lower in the pentoxifylline group versus 46% in the placebo group. And this was mainly because of reduced risk of hepatorenal syndrome. Subsequent meta-analysis did show that it might improve short-term mortality, but most of these studies had high risk of bias and there was an increase in adverse events. So this drug also has not picked up that much in terms of use in alcoholic hepatitis. And the final nail in its coffin was this large trial called the STOPA trial, which was a double-blind placebo-controlled trial, 1,100 patients, 65 UK centers, patients with severe alcoholic hepatitis, bilirubin more than 4.7, 4 groups, placebo, placebo, prednisolone, placebo, pentoxifylline, placebo, prednisolone, pentoxifylline. No difference. No difference over placebo, either in combination or alone, either steroids or pentoxifylline. However, in the prednisolone group, there was some trend towards lower mortality when steroids were given. Again, the same depiction. Further, the adverse events increased infectious complications were seen in patients who were given prednisolone as compared to non-prednisolone. Finally, a latest meta-analysis, 11 RCTs, more than 2,100 patients. The 28-day mortality was significantly lower with corticosteroids when compared to controls or when compared to pentoxifylline, but this was just 28-day survival. The long-term survival, no effect of steroids, and there was no role of combination of steroids plus pentoxifylline. I think we'll stop here for part 1 and start the part 2 after a short discussion.
Dr. Nijavan, please.
Yeah, many questions pouring in. So we'll take few questions with a very crisp answer. It was an excellent talk by Kaushal, so almost everything was clear. There's one question from Anand from Chennai, who is asking that leukocytosis does occur in alcoholic hepatitis, but how to differentiate between leukocytosis of infection and alcoholic hepatitis?
I'm sorry that I did not cover this, but yes, leukocytosis and many a times neutrophilic leukocytosis is part of the syndrome of acute alcoholic hepatitis. But if it is associated with other features of sepsis like persistent high-grade fever, then you should suspect an underlying infection and aggressively look for infection, sending all cultures, including ascitic fluid cultures, urine cultures, blood cultures, and X-rays. If there is still a doubt, then you may resort to doing a procalcitonin levels, which might help you suggesting whether the patient is harboring sepsis or not. And there are some studies which have looked at the role of procalcitonin in this scenario.
There was one more question from Jayesh, again from Chennai, that what is the role of neutrophil lymphocytic ratio in alcoholic hepatitis?
Again, neutrophil leukocyte ratio might suggest that patients in a particular patient where you have to differentiate between alcoholic hepatitis and some other cause of hepatitis, it might suggest that patient has alcoholic hepatitis as the cause of liver disease.
There was one question from Shiva Prasad from Visakhapatnam, that a person with a history of 3 days of abstinence and person with a 59 days of abstinence, these two groups are to be stratified differently, or they should be taken in the same category for treatment?
Yeah, so although there are no clinical criteria which has been described, but yes, logically it makes sense. A person who has recently given up alcohol is more likely to improve by conservative treatment than a patient who's left alcohol 59 days back and is equally sick. This patient is unlikely to respond to conservative treatment or medical treatment. So these are the ones who are having a prolonged abstinence and still having a severe disease are the ones who should be pushed for transplant.
There is one question from Dr. Sudhir from Jaipur, that if there is a coexistence of NASH with ASH, how are you sure that which is causing the disease? Are there any markers or any clinical way you can differentiate the two?
In a particular patient, if you do a liver biopsy, you might find overlapping features. I think the most important aspect is to have this history of alcohol intake, which will guide you, and certain features on liver biopsy like neutrophilic infiltration, which is not seen in NASH but seen in alcoholic steatohepatitis, which will help in guiding this. In addition, there are certain markers, there are certain serum markers, urinary markers might help you in suggesting that patient might have had alcohol abuse which led to this. But they are also useful for the excluding alcohol intake in last 2 weeks. Say a person who says he's given up alcohol 1 month back, you will not be able to differentiate using these markers.
There was a question asked by two people, Arun from Lucknow and Lohit Kumar from Bangalore, that if in a patient CT is contraindicated, then can you go ahead and do ultrasound to rule out underlying chronic liver disease in the setting of alcoholic hepatitis?
No, I wouldn't say that. I wouldn't say ultrasound is that sensitive in making such a diagnosis. You can do an MRI. What I want is a cross-sectional abdominal imaging. Ultrasound will not fit the bill for this particular case.
And there's one more question from Dr. Vishnu from Jaipur, that we have so many prognostic markers for severe alcoholic hepatitis. Which is the best one? And is combination of markers better than using a single one?
So I just presented that. I think the ones which are in vogue are easy to use and best validated are the Madri's discriminant score, the MELD score, and the Lilly score. So, and in clinical practice, all of us have been using this for many years.
And there was one more question, like patient of severe alcoholic hepatitis, we want to treat them with steroids, and they have co-infection with hepatitis C and or hepatitis B. So what to do?
So I would say it would be difficult to make a diagnosis of alcoholic hepatitis in presence of active viremia with hepatitis C and hepatitis B. It is possible that a lot of injury which is happening could be viral related. So first you have to start these patients on antivirals any which ways. and thereafter he is not improving, then consider starting steroids. I'm sure that if they have active viremia, most of the liver injury would subside with antivirals themselves.
There's one more question from Mangesh from Pune. That how will you treat a patient of alcoholic hepatitis in pregnancy?
I'm surprised a patient. Yeah, that's a very tricky clinical scenario. A patient of alcoholic hepatitis with pregnancy. I think the most important here, the issue here would be to ensure abstinence. I think many of these patients will improve, and give them good nutritional therapy and maybe non-specific hepatoprotective agents. However, if patients do reach a stage where where you have to decide or take a decision regarding some aggressive therapy, then yes, the steroid should not be a contraindication here. And even a liver transplantation should not be a contraindication here. We've had many liver transplantations done in acute liver failure with pregnancy. Why not alcoholic hepatitis who's dying and requires a transplant? Pregnancy should not withhold us from offering aggressive therapy.
Definitely, Yavan, can we go to
sure.
maybe come back?
Yeah, sure.
Yeah. So shall I move forward?
Yes, Qasim.
Yeah. So here we stop the chapter of steroids and pentoxifylline, one of the most controversial issues. So now we move on to certain other drugs with doubtful efficacy in alcoholic hepatitis. One of them is N-acetylcysteine. The major role it plays in alcoholic hepatitis is because of its free radical scavenging activity and therefore its antioxidant effect, and also have anti-inflammatory properties. This was an initial trial of N-acetylcysteine along with enteral nutrition versus enteral nutrition alone, given for 14 days. And then they looked at the 1 month and 6 month survival, and it was not found to be different. Then there was a study of combining N-acetylcysteine with prednisolone or steroids. So 174 patients with severe alcoholic hepatitis. This was published in NEJM. Prednisolone plus N-acetylcysteine for 5 days infusion versus prednisolone alone plus placebo infusion. Significant number of patients, 85 and 89. And as you can see, the group which was given prednisolone plus NAC versus prednisolone alone, the short-term mortality was significantly lower, but the 3-month mortality was not different, despite the fact that the group which received prednisolone and NAC had a lower incidence of HRS. Coming to other hepatoprotective agents, and I'm sure there must be questions after this talk is over about all these issues. So I thought I'll spend a little time here. Ursodeoxycholic acid, because these things are available in the market and used rampantly in patients with alcoholic liver disease. S-adenosyl methionine and metadoxin. So let me tell you that with UDCA, there is no randomized control trial of alcoholic hepatitis, but all of us are guilty of using UDCA in patients of liver disease or alcoholic liver disease where we do not have any other drug to give. Second is S-adenosyl methionine. It is a methyl donor. It replenishes glutathione reserves in the liver, which act as a major antioxidant defense. So in a study which was done many years back in patients with alcoholic cirrhosis, not alcoholic hepatitis, alcoholic cirrhosis CTP-A and CTP-B, they had excluded child C cirrhosis. This drug in IV formulation was shown to improve survival. The p-value was 0.04. Coming to metadoxin, basically a repurposed drug. Many years back, almost 10 or 12 years back, it resurfaced for use in alcoholic liver disease or alcoholic hepatitis, predominantly as an antioxidant. And now there has been a resurgence. There is one randomized control trial, but it was an open label, sorry, not open table, open label RCT, 4 groups, around 30 to 35 patients in each. Prednisolone plus metadoxin, pentoxifylline alone, pentoxifylline plus metadoxin, 500 milligram thrice a day. The 3 and 6 month survival were found to be significantly better in the metadoxin group, but possibly it was a less than robust study. What is more important is this, that patients who were given metadoxin, the maintenance of remission, that is, patients remained off alcohol more frequently than in the group who were not given metadoxin. So this particular aspect of metadoxin has not been explored earlier, and maybe this effect can also be used when we are prescribing this drug in alcoholic liver disease. Step 5. So we've talked about medical management. We come to non-medical management. Patients who have no other options of treatment, or patients who have failed treatment with steroids. So for example, if you have started them on steroids and their Lilly score is more than 0.45 or 0.56 and you are not finding any improvement, those are the patients you have to decide fast whether they would want to go for liver transplantation or not. The issues with liver transplantation for alcoholic hepatitis and why there is so much debate is because of this. So these patients, when they have no other options to fall back upon, liver transplantation can provide them a good survival, and we'll discuss that data. The second issue which is often discussed is the period of abstinence required before these patients are referred for transplant. So classically it used to be 6 months, then it came down to 3 months, and now there are a lot of centers which are transplanting these patients with 1 month of abstinence. The third issue which is often discussed is that since these patients so suddenly develop this hepatitis, they've not had time to think about abstinence. So they just undergo transplant, which leads to a very high risk of post-transplant recidivism, leading to further damage of the graft and graft failure. So many people argue that such patients, if you do transplant, they will have a very high risk of post-transplant graft failure secondary to repeat drinking habits. The fourth issue is transplanting a liver in a presence of acute inflammatory response. Will this liver be taken up well or not? Or will these patients survive in presence of such a hyperimmune inflammatory response in these patients? So this was the first study which addressed it by Dr. Mathurin, published in NEJM. 26 patients with severe alcoholic hepatitis with a mean Lilly score of 0.88 were taken up for early liver transplant, and that was as early as within 13 days of admission. We are talking about 6 months, 3 months, and 1 month. This is 13 days of admission. The 6 months cumulative survival was 77% in those who were transplanted versus 23% possibly in those who were not transplanted. So again, suggesting that almost 80% of patients could be salvaged. So the issue of patient having inflammatory response not leading to a better survival was debunked. And then there was this large trial from US, 147 patients from 12 centers from US called the Accelerate Alcoholic Hepatitis Trial. Most of these patients had first episode. The median abstinence was 55 days. Here it was almost 2 months. The median Lilly score was 0.82 and the MELD was 39. And look at this, the 1 year survival 94%, 3 year survival 84%. So if you transplant these patients who have failed treatment on steroids or who do not have any option, 85 to 90% patients you can give them long life. But yes, patients who, the dotted line, patients who did have recidivism, the survival was significantly lower as compared to those who did not restart drinking. Again, suggesting the risk of recidivism or alcohol relapse was almost 30% over 3 years' time once these patients were transplanted early for alcoholic hepatitis. So now that brings us to the issue of alcoholic ACLF, the one I discussed earlier. So when we are selecting our patients for steroid therapy early on, it's important to differentiate patients who have alcoholic hepatitis versus those who do not have, who have alcoholic ACLF. So possibly many of us who've been using steroids without differentiating this point, these are the patients who are likely to develop complications, likely to develop infections, and likely to die because of corticosteroid therapy if you are not able to differentiate alcoholic hepatitis from ACLF. So what about transplantation for alcoholic ACLF? 388 patient, this is their natural history. So if they have ACLF grade 3 at day 3 to 7, the survival is only 3.8%. If they have no ACLF, it is 62%. Now compare them with this ACLF grade 2 or 3 if they were transplanted. Transplanted patients, 80% survival at 180 days versus only 10% if they were not transplanted. So alcoholic ACLF patients, if you do not transplant, then the mortality rate is very high. And if you transplant them early, you'll be able to salvage most of them. Another study, 73 patients with grade 3 ACLF. And remember, most of these ACLF cohorts, the most common cause of ACLF has been alcohol. So grade 3 ACLF underwent liver transplantation at a median of, median of 9 days after admission. The mean MELD was 40 and CLIP-C ACLF score was 63. And again, look at this. With transplant, long-term survival, 1 year survival 83%, without transplant 79%. So this is our own data from MAX. ACLF patients who underwent transplant 77, ACLF patients who did not undergo transplant. Those who were transplanted, more than 80% survival at 1 month. Those who were non-transplanted, less than 50% survival at 1 month. So liver transplantation is a very good option for alcoholic hepatitis as well as patients for alcoholic ACLF. For alcoholic ACLF, I feel this should be the first line of treatment, whereas for alcoholic hepatitis, those who have got large livers, steroids may be the first line of treatment, provided you select your patients correctly. The step 6 or the final step, novel treatments of alcoholic hepatitis for patients who do not have any other options. I told you that alcohol leads to dysbiosis. It also leads to a leaky gut. There is disruption of tight junctions in the intestines between the cells. These abnormal bacteria as well as their products, they cross over because of the leaky gut into the portal circulation. These are called PAMPs. They reach the liver, hepatocyte, hepatic Kupffer cells. They bind to the TLR receptor, activate these Kupffer cell, release cytokines like TNF, IL-1 beta, which leads to damage or propagation of inflammatory response, which damages the hepatocytes. So targeting the microbiota. So this was a study on fecal microbiota transplant in 8 patients with severe alcoholic hepatitis from ILBS, where the patients received daily infusions of donor feces through the nasojejunal tube for continuous 7 days. And they showed that patients who were given these 8 patients, the survival was 87% versus 33% in retrospective controls. However, this is a small study. This needs to be validated in large randomized control trial, which should be prospective before this can become a standard of care. And remember that this is not a simple therapy. There have been reports of mortality secondary to fecal microbiota transplants. This cannot be taken lightly. It has to be first tested in large randomized control trials. The second is the concept of GCSF, or the growth factors, which lead to mobilization of bone marrow derived stem cells, which can potentially home into the liver and aid in liver or hepatocyte regeneration, leading to recovery from ACLF. So this was a study from ILBS, which suggested that the CD34 positive cells, which were supposed to be the bone marrow derived stem cells, this was the pre-therapy liver biopsy immunohistochemical staining of CD34. Pre-therapy, the staining was only 30%, and post-GSF therapy, it had improved to significantly to 70% after treatment with GCSF. So this was a study again on alcoholic hepatitis of a randomized control trial, 46 patients from PGI Chandigarh, where GCSF was given at a dose of 5 mics per kg every 12 hourly for 5 days versus standard medical therapy. And they showed that the 3-month survival in the GCSF group was significantly better than in the standard medical therapy group. And recently, another severe acute hepatitis patients who were non-responders to steroids were given GCSF versus placebo. This was the study from ILBS. Although there was no difference in mortality or survival at day 28, but the 90-day survival was significantly better in the GCSF group. The mortality was lower as compared to the group which received placebo. Sorry. So to summarize here, ladies and gentlemen, alcoholic hepatitis is a frustrating illness with a very high short-term mortality in severe acute alcoholic hepatitis. Although liver biopsy is the gold standard for making a diagnosis, but the diagnosis can be made clinically in most of these cases, and liver biopsy is only required when some other diagnosis is suspected, or you want to rule out the presence of alcoholic hepatitis in a patient who's not forthcoming with his history of alcohol intake. The assessment of severity is very important for both prognostication and to guide further treatment. Mild alcoholic hepatitis can be managed with supportive treatment only, and it goes without saying that you have to ensure abstinence even in these patients. Just because they had mild hepatitis and they could easily be discharged from the hospital does not mean that they can intermittently continue to drink, and that they have to be impressed upon that it could lead to a higher mortality later on in life. Whereas severe alcoholic hepatitis will require specific therapy, corticosteroids are possibly the only therapy which has been shown to be associated with improved short-term survival, but not long-term survival. Patient selection when you are using corticosteroids is the key to have a successful outcome. Severe alcoholic hepatitis with hepatic encephalopathy, without GI bleed, and without the presence of infections, and after excluding alcoholic ACLF is possibly the best group in whom you can offer corticosteroids. When you start corticosteroids, monitor carefully with the Lilly score at week 1. Stop steroids if it's more than 0.56, else you will increase the risk of sepsis and mortality. Non-responders to steroids or those who have no other options will benefit from liver transplantation early, and liver transplantation, irrespective of the fact that you are doing it early, will provide good survival rates in these patients, almost to the tune of 80 to 90%. Before starting steroid, again, it is important to differentiate between alcoholic hepatitis and alcoholic ACLF, and those in whom you think the patient has ACLF should be offered liver transplant upfront, because steroids possibly may render them unsuitable for even transplant. And abdominal imaging may help in this differentiation. Finally, novel therapies which have shown some benefit are growth factors like GCSF and fecal microbiota transplant, but their significance, their use, their efficacy has still to be proven in large prospective randomized controlled trials. Other future therapies which we can look forward to are therapies like, since it's an inflammatory state, anti-inflammatory drugs like anti-IL-1, anakinra, IL-22, which helps regeneration in the liver, bovine colostrum, which modifies or targets the gut-liver axis modulation, and silonsertib, which has an anti-inflammatory, antioxidant effect. Thank you for a patient hearing. If you want to ask me questions first, you are most welcome. Otherwise, I'll put 2 questions first to the audience, whichever way you want to proceed.
I think you go ahead, Kaushal. Let's have the questions for the audience before we take questions from the audience.
Right. So just 2 simple questions. The answers were there in the talk. The following group of patients are best suited for steroid therapy. A, alcoholic ACLF with grade 1 hepatic encephalopathy and no GI bleed. Alcoholic hepatitis with grade 1 hepatic encephalopathy and melena. Alcoholic hepatitis with ascites with high fever and high TLC. D, alcoholic hepatitis with grade 1 hepatic encephalopathy and mild ascites. I think it's very simple.
And those who are on Facebook can answer by writing A, B, C, D.
Should I move on to the next question, or we want to wait for the answer on this?
Let's wait
And
for
we'll
the
discuss.
answer. Yeah. And you addressed this question very well in your talk, Kaushal. Amol, can we have a answer, please? Response. So most people say that almost 74% say that alcoholic hepatitis with grade 1 hepatic encephalopathy and myelocitis. That's answer D.
Fantastic.
23% says 1. Yes.
So the only thing, again, I want to reiterate is that alcoholic ACLF is not the group where you would want to give steroids. If you are sure that patient has alcoholic hepatitis, so the group which will benefit most is the one which has a true alcoholic hepatitis, a large congested fatty liver. So these are not the patients who have, and they will have just minor features of portal hypertension. So those are the ones you should pick up. So alcoholic ACLF upfront, in my opinion, should be offered transplant before you even consider giving them steroids. They should at least be talked about the option of liver transplant before putting them off steroids. So the next question, which of the following about alcoholic hepatitis is not true? A, aggressive enteral nutritional therapy should be given as it has been shown to improve survival in randomized controlled trials. Sorry. Lilly score best predicts the response to steroid therapy. Pentoxifylline has shown no survival advantage in patients of alcoholic hepatitis in the large STOPA trial. Severe acute alcoholic hepatitis is basically an inflammatory disease. Not true.
This is a tricky question, Kaushal. Yes, Amol, so we have a now response. Response, most people say that almost 81% that aggressive, the answer 1.
That's correct. I think they've understood the concept well, all of them.
Absolutely. Fantastic. So we can have a questions, Dr. Saraswat. Unmute, please. Unmute.
Sorry. Kaushal, the compliment you get for your lucidity of your talk is that you get to answer about 400 questions.
My God.
400. This is a record as far as I can recall for any of our masterclass sessions, and I think they're still pouring in. Well, I think I'll try and make a beginning, maybe cover 7, 8, 10 of these. Right, Dr. Anand from Mumbai wanted to know, how will you decide the grams per day consumption of alcohol in people consuming desi alcohol, indigenous country liquor? Say 1/4 of desi liquor, how many grams per day of alcohol would that be?
So that's a very difficult question because most of the description is based on the percentage of alcohol in a particular spirit or in a particular drink. In these desi alcohols or desi drinks, it's very difficult to, because it's not standardized. The amount of percentage of alcohol in these is not standardized. So it's anybody's guess, but I believe that they contain about 40 to 60% alcohol. So normally we use a unit as 30 ml of standard alcohol, which is 40% alcohol, is equal to 10 grams. So you can safely say that these would be containing between 10 to 15 grams of alcohol, or 30 ml of drinks from these spirits.
Right. So a quarter would probably be 2250 grams. So that would come to quite a bit of alcohol. 10
Quarter,
grams
quarter
per
would be about say about
30 grams
150
or
or
so.
170 ml.
Yeah.
So around 75 gram to 80 grams of alcohol.
Right. Okay. Now, regarding these anti-craving medications, there's a question from Dr. Anand in Mumbai again saying whether baclofen can be continued in people with decompensated cirrhosis. And I think I'll just put a couple of other questions about Dr. Akash Roy from Chandigarh also wanted to know in the severe form, severe alcoholic hepatitis and ACLF, is there still a role for anti-craving medicines, medications like baclofen? While Dr. Manoj Joshi from Haldwani wanted to know is what is the place for disulfiram in the today for de-addiction or for as anti-craving?
So first question is baclofen. Yes, baclofen can be used for alcoholic cirrhosis, and it was in fact the RCT was done in patients with alcoholic cirrhosis. And although this study was for short period, 3 months, I had rushed through the other study in which it was also used for 12 months, which was a retrospective study, and it maintained abstinence in 97%, but I don't believe that personally. I have never had patients who have 97% patients who've been able to maintain
Abstinence.
abstinence, despite the fact that I put all my patients on baclofen once they are discharged. Second issue is, can anti-craving medicines be given in acute alcoholic hepatitis? I think once these patients are in the hospital, possibly there's no role of giving them anti-craving medicines, but it's best to start them as an overlap before they are getting discharged and continue them after discharge, because that is the time when they are likely to relapse once they go home. Till the time they're in the hospital, they are safe. The third question was disulfiram. So most psychiatrists and us also are scared of using disulfiram in patients who have acute icteric alcoholic hepatitis. We would want that to settle down before we put them on disulfiram and send them home. And frankly speaking, I don't have much experience myself in using disulfiram. We refer most of these patients to a psychiatrist.
Right. Okay. I think you spoke about the Lille score on several occasions, Kaushal, and the general practice has been to look at day 0 and look at the Lille score on day 7 before you come to a decision. So Dr. Jagdeep Patel and Dr. Akash Roy both want to know how about looking at the Lille score earlier. Jagdeep says, why? How about day 4? While Akash Roy wants to say, know whether day 3 or day 5 assessments would be more useful, because often continuing for 7 days may be a problem. Is there any data on that?
Yeah, I am not aware of any data. And you would want to give time on the liver and the inflammatory system. I think 3 or 4 is too early to expect a response. So give some time, at least give 7 days for it to start acting. Only then you can gauge whether the effectiveness of steroids. So I think I don't agree at measuring it at day 3, 4.
Right. Okay. An interesting question from Dr. Abhinav Kumar in Bangalore. OCA, obeticholic acid for severe alcoholic hepatitis. Any reports, any information?
So there is an ongoing trial on that, but we don't have any results now. Again, like I said, that some of the mechanisms which drive non-alcoholic steatohepatitis are also postulated to be driving the inflammatory process, albeit in a very severe manner in alcoholic hepatitis also. And all these drugs which have been tried, in fact, most of them like silonsertib, obeticholic acid, Senis-Riviroc, which is a CCR25 antagonist, all have been tried or are being tried in alcoholic hepatitis as well. But we don't have any data right now. And since that's a very pertinent question, since OCA is now available, I think we should not be promoting this kind of use or abuse, I would say.
Okay. Okay. I think, as you can imagine, the bulk of the questions is about corticosteroids, how to use and what to do with them. Dr. Gunjan from Rajkot wants to know, what do you do at the end of 4 weeks of steroid therapy? You give 4 weeks full dose and then taper? You taper within 4 weeks, or is there a taper after 4 weeks? How do you taper steroids after 4 weeks?
So if the patient has responded well at 4 weeks, I usually taper it over next 2 to 3 weeks. Give full doses for 4 weeks and then taper. That's the policy I follow. But like I think most of the hepatologists, including yourself, we have not treated very many patients with steroids, and many of these patients, we have also burnt our fingers when they've developed septic complications.
Right. Okay. So I think what should be the minimum workup for sepsis or infection that should be done before steroids? On this, there are a lot of questions. Dr. Shiva Prasad wants to know again from Vishakhapatnam. He's listening very keenly to your presentation, Kaushal. Leukocytosis with neutrophilic leukocytosis could be infection, could be SIRS. So what is the test that you do to identify infection before putting people on steroids when leukocytosis is present? And similarly, Dr. Waifio from Myanmar also wants to know, how do you exclude infection before steroids?
Okay. That's an important question because before you start steroids, you want to be sure. And the answer to that is there is no single parameter which will tell you whether the patient has or does not have sepsis. It has to be an approach where you want to get inputs from multiple sources. So TLC and fever is just not the ones, because they will be as such raised in patients of alcoholic hepatitis. So you want to have all kinds of cultures which can be possible. So even without culture, a simple test will be rule out an SBP. Apart from that, the cultures of ascitic fluid, urine and blood, X-ray chest, if in doubt, a CT chest, and as mentioned earlier, a procalcitonin also may guide you. And once these patients are in ICU, you are regularly getting their ABGs done. So a lactate level also is a very sensitive indicator whether patient may be harboring some septic focus or not.
Right. And the continuation with this, Dr. Anirudh Tiwari from Bhubaneswar is asking, if you have a patient who has severe alcoholic hepatitis and also clear-cut established sepsis, how would you go about treating him? He's a candidate for steroids for a severe alcoholic but has an active infection.
So obviously these patients, the active infection first has to be brought under control. They have to be given broad spectrum antibiotics. If you have a culture positivity, then your treatment can be guided by that. But if you do not have a culture and you are suspecting a septic complication, then you put these patients on broad spectrum gram-negative antibiotics. And if really these patients were sick because of sepsis, let me tell you, even their liver functions will improve once their sepsis gets under control. So many of them probably won't even require steroids after that. But once you control these sepsis, you are sure that you've got culture negativity in a particular patient and he still is having severe alcoholic hepatitis, then you can start them on steroids with antibiotic cover continued.
Right. So in this continuation, I think Dr. Gunjan Joshi from Rajkot says that he has lost 4 patients on steroid therapy to fungal infections. So is there a place for empirical antifungal treatment when you are starting steroids for severe alcoholic hepatitis?
Not an empirical, I wouldn't say that antifungal should be started empirically, although we used to follow that policy, or we still follow that policy in acute liver failure, but not in acute alcoholic hepatitis whom we want to put on steroids.
Right. I think that this other question that I have here is from Dr. Sagar in Delhi, who wants to know about futility rules. Is there any upper cutoff for MDF or any of the other scoring systems above which steroids would not?
Yeah. So I think the connection got disconnected, Dr. Saraf.
Yeah, sorry, can you hear me now?
Yeah, now it's okay. So the futility rules, I did mention about that there is some data to suggest that if the MDF scores are beyond 54 or 55, then possibly steroids may cause more harm or may be ineffective. And this point has been discussed many times in such meetings and discussions, wherein all of us believe that most of our patients have very, very high MDF. We rarely see patients who have an MDF between 32 and the upper cutoff of say 54 or 55 or even 60. Once these patients have severe alcoholic hepatitis, their MDFs will be in the range of 80, 90 or 100. So
Right.
it is difficult to select these patients. And again, I said, although you might not find this in books, I think it's very important to exclude patients in whom you can confidently say that although they have very high jaundice, but they are actually alcoholic ACLF. So let's not give them steroids.
Right. I think the other side of this is what Dr. Ankit from Kolkata wants to know, that is there any value for MDF or MELD or any scoring system above which you would say that if he's above this, the patient should directly be taken for liver transplant and not given steroids? I think some ways you answered this, but this is slightly different phrasing.
Right. I wouldn't say the cutoff to be used of these objective criteria, but overall clinical condition, as I mentioned earlier, would be a better guide than the cutoff of these values.
Right. Okay. I think there are a few of these earlier questions regarding diagnosis also. I think this was also partly addressed in your talk. In people with alcoholic steatohepatitis and non-alcoholic steatohepatitis, what would be the differentiating features on liver biopsy, particularly when a person is obese and is consuming alcohol and could have both present in the tissue in the liver? So you listed polymorph leukocytosis. Any other features that might be of help differentiating ASH and NASH?
Yeah, polymorphonuclear leukocytosis one. Chicken wire fibrosis also more likely suggests alcoholic hepatitis than NASH. And these features of Mallory-Denk bodies and all would be more prominent in patients who have alcoholic hepatitis than NASH.
For percutaneous liver biopsy, Gunjan Joshi from Rajkot is again asking, what are your standard cutoffs for INR and platelet count prior to percutaneous liver biopsy? Are they any different?
Standard cutoffs are 60,000, below 60,000 platelet and an INR above 1.5. I would be very scared of doing a liver biopsy percutaneously. And in these patients, I would, even if the INR is say 1.6, many people would say that give an FFP and go ahead. I would say that even in these patients, it would be better to prefer a transjugular liver biopsy approach, although it is a bit expensive.
Right. So now I think differentiating in the use of steroids in the presence of or without cirrhosis. There has been, I think the entity of steroid related ACLF is something that people are not very familiar with. So they want to know that if a person has significant ascites, there is evidence of clear-cut established cirrhosis and alcoholic hepatitis, would you still go ahead with steroids or would you avoid steroids in this subset?
So alcoholic cirrhosis with a small liver and features of advanced portal hypertension. So this is the group I would say you should avoid steroids. And if there is still no option and the patient might be, or the family might be pushing you, then they must be told that the risk of complications are very high. They may opt for certain experimental therapies. I'm sorry, I did not mention about the role of plasmapheresis here. So again, if you want to consider experimental therapies, then say GSS, GCSF or plasmapheresis may be considered here.
Okay. Maybe I think Dr. Sandeep would have some questions that you could put to Dr.
Yeah, there are a few questions actually. Sangeeta from Jaipur, Arun from Chennai, Kshitij from Rishikesh. That what do you say about use of GM-CSF role in treating severe alcoholic hepatitis, according to the literature?
Like I mentioned, there are small studies, especially from this part of the world, from our part of the world, both from PGI, ILPS, which has used GCSF both in alcoholic hepatitis as well as ACLF groups, and found that the survival was better in the group which was given GCSF. But there have been other studies from Europe, and recently in last year's ASLD, they had done a randomized control trial, multi-center, of GCSF in alcoholic ACLF, where it was not found to be effective. So right now it can only be considered as an experimental form of therapy. If you have no other options, after informing the patient and the family, you can try these both factors.
And there were multiple actually people who want to know that how will you differentiate clinically between alcoholic hepatitis and ACLF? Because treating ACLF will have a far more poor prognosis. So, are there any clinical criteria to differentiate?
So again, I did point out that clinically, both these patients may have ascites, both these patients may have some amount of encephalopathy, and both these patients may have mild portal hypertension. So clinically speaking, it may be very difficult unless you do a liver biopsy or you do a cross-sectional imaging in which you are able to demonstrate a small liver versus a large liver and presence or absence of significant number of collaterals.
There's a question from Dr. Rai. He wants to know about the role of new Mayo score system to differentiate between NASH and ASH.
I'm sorry, I'm not aware of this.
Yeah. Then there are multiple actually calls to have your opinion about role of IV glutathione in treatment of alcoholic hepatitis. Can it be used instead of NAC with steroids?
So as I told you, glutathione was a major antioxidant defense in the liver. That is why drugs like acetylmethylene for replenishing glutathione, metadoxin, and N-acetylcysteine have been used earlier. And now we also have IV glutathione as well as oral glutathione preparations available in the market. And again, like people have been using UDCA or other hepatoprotective agents, people have also been using these. No data to suggest that they improve survival.
Girish from Cuttack wants to ask treatment of coagulopathy in patients of severe alcoholic hepatitis not responding to fresh frozen plasma and vitamin K.
I'm glad somebody asked this. Like in most diseases, patients who have coagulopathy and are not bleeding, there is no indication to replace fresh frozen plasma. Only when these patients are undergoing an invasive procedure or are actively bleeding from somewhere, then also the recommendations are, or at least the replacement of these factors should be guided by point of care coagulopathy tests like TEG or ROTEM.
And Dr. Nikhil from Jaipur wants to ask, what is the role of TPN in severe alcoholic hepatitis?
So, as I mentioned earlier, you want to give these patients high calories and high protein in their diet. However, the trials which have looked at either enteral feeding or TPN have failed to demonstrate any survival benefit. But a patient who is nil per oral for more than 3 to 5 days in an ICU and you want to feed them, then both enteral as well as parenteral nutritional options are available and can be used.
Sorry to jump in. I think there's a very impertinent question in this continuation. Dr. S.K. Mishra from New Delhi wants to know, how do you ensure 2000 calories per day plus 100 gram protein in ACLF with 4 organ failures? I mean, it's easy to prescribe, but to ensure the consumption is a huge challenge. What do you think on that, Kaushal?
I totally agree. And again, I would say that a patient who's unable to meet any patient who's critically ill and is a cirrhotic is unable to meet his daily protein and calorie requirement. You have to supplement it by either putting a Ryle's tube and feeding enterally or by doing a TPN. But again, I'm saying this is not as part of the treatment of alcoholic hepatitis, but the nutritional management of any critically ill cirrhotic.
Right. Sorry, Sandeep, to jump in.
Yeah.
Go ahead.
There's one question from Dr. Vivek Bhatia. Role of fibroscan to differentiate between severe alcoholic hepatitis and ACLF.
Again, I'm glad that somebody brought it up. I remember Dr. Gordas telling me, whenever you present a talk, do not present everything. Because one, you will never be able to complete your talk, and second, people will get bored. So I'm glad people are asking those questions which I have missed in my talk. So the role of fibroscan, once a patient has acute alcoholic hepatitis with high enzyme enzymes and high bilirubin, the fibroscan done at that stage will give a falsely high reading. So I don't do, and I think most people defer doing fibroscans in a stage of acute alcoholic hepatitis. And it is recommended that once the enzymes come to less than 100 and bilirubin less than 2, that is the time you should do a fibroscan to say whether patient has underlying cirrhosis or not.
There was one question from Dr. Girish from Kotak. The role of non-invasive biomarkers for diagnosis of acute severe alcoholic hepatitis.
So I think role of non-invasive biomarkers for detecting severity, we don't use that regularly because they've not been standardized. Second is the role of biomarkers to find out whether there was a surreptitious alcohol use or not. So those are in vogue, but most of these are not routinely available and are misleading many times. So the best way is to find out from history. And as I mentioned earlier, if it's more than 15 days or 3 weeks in the hospital and you're sure that this person or in the healthcare, this person for last 2 to 3 weeks has been off alcohol, at that time these markers possibly won't help you much. Except I think the most commonly used is gamma GT levels. Apart from that, nothing helps you much in clinical setting to make a decision. Although a number of them have been described.
Can we stop that?
Yeah, sure.
Here? A couple of things I want to make a Kaushal. Since you are a Secretary General of INASL, do you want to recommend, since you are aware of the practice of treatment of alcoholic hepatitis in our country, do you want to recommend anything specific that we should follow, whatever we do, either over practice or under practice?
I think I emphasized that multiple times in my talk, that we might, including myself, we might be guilty of using steroids indiscriminately in some patients. And one thing which I have learned over last few years is the fact that it should be avoided in a patient who has a true alcoholic ACLF. So those are the patients upfront who should be told that no kind of medical therapy are going to help you. So consider getting a liver transplant done seriously. If liver transplant is not an option, then we can think of other therapies.
One more point I want to hear your opinion on, that the behavior of healthcare personnel and also the family towards the patient. By the time they have alcohol dependence, this is a disease, this is not voluntary. And as soon as you stop alcohol, they start craving. And this is the point where all the family and healthcare workers start telling that you don't stop alcohol, you don't stop alcohol. So it's your fault. But fault may not lie with the patient at this point of time because it's a too advanced disease. And therefore, our whole of approach of the healthcare system and also the family should be towards sympathetic and empathetic towards the patient, and taking him into consideration that he's suffering from a disease and which is far advanced. And where we feel that a lot of families will always try to raise their voice on the patient, but this may not be required. And as you already pointed out, that de-addiction should be a very, very important measure to be done in alcoholic hepatitis. Do you have any comment on this, Kaushal?
I totally agree. And I think it should be part of the treatment and part of the rehabilitation plan before we discharge the patient, of creating a psychological support system around the patient, involving the family members as well as the patient's work environment and social environment, concentrating on that. So I agree that it has to be inbuilt in the treatment plan of these patients. Yes, while we are hepatologists and gastroenterologists, we are just concentrating on managing acute alcoholic hepatitis, and we have that feeling of success if we are able to discharge these patients. And we generally tend to forget that most of these patients, actually most of them, do come back with a second episode or third episode and possibly lose their life in one of such episodes. So I think we have failed to address that issue as hepatologists, because we feel that we have succeeded once we treat a particular episode. I agree with that.
Thank you, Kausal, so very much. Your talk has been so popular that we have 551 questions. 551. This highest ever.
Maybe people did not understand much.
It's not because there's
There are a lot of things to ask actually.
a lot of controversies around this topic, and this is what your popularity is. And so, therefore, you have to stop your practice for the next 7 days to address to some of these questions. And we look forward to receive from you these questions. Anyway, this question will send to you. Dr. Saraswat and Dr. Nijavan tried to cover not many of such questions, which have been very, very relevant. So we will send these questions to you, and we look forward to see your responses. Kausal, I want to tell a couple of things about your talk. Your talk have been remarkable, and why I say remarkable? For two reasons. That you divided your talk into stepwise. So you crystallize talk into diagnosis, what to do each step. And this is very important for learning. That you, as we see the dance is never a very complicated issue, and you learn by step by step. So step 1, step 2, step 3, step 4, and then you make a beautiful dance. And says about teaching in medicine that is all those complicated, you break into small topics and then compile everything together. And that's what you do so wonderfully. And we all of us enjoyed your talk very much. Thank you, Kausal, for such a beautiful talk. And I'm sure that I'm going to go back again to see this talk on ISG library and revise myself if anything I missed out from your talk. And thank you so very much.
Thank you.
Thank you, Dr. Nijavan, for agreeing to moderate this session. You have been so wonderful always, and we all know that Dr. Nijavan is the treasurer of Indian Society of Gastroenterology and always very supportive. And recently has granted money to create a infrastructure for Indian Society of Gastroenterology to be done in Delhi. And Dr. Ajay have been requested to find a space for ISG office, and that's a remarkable thing, Dr. Nijavan, you did.
Thank you so
And
much.
I think this was decided in the last governing council that we should have our own infrastructure, and therefore we can archive all our records, and we have our own office. Thank you, Dr. Saraswat, again for supporting all the ISG activities, and this has been a remarkable year in terms of starting many things in our society, including Masterclass, which have been going so well. And we are so happy that the Masterclass till now have been a wonderful experience in terms of quality of presentation and in terms of our learning. So thank you so very much, Dr. Saraswat, for supporting and taking leading us on all these activities in our society and gastroenterology at large in our country. We want to thank Sun Pharma, that Sun Pharma have been supporting all last 16 of these master classes, and we had all the quality of presentations have been so well, all because of their support. Especially I want to thank Mr. Ramesh Nagarajan, who have been supporting all through, and Amol Nalawade, who have been helping us in technical aspect. Thank you, Dinesh. Dinesh is the person from IT, and they host our meetings, and he have been very creative every time to help all the speakers if there are any technical glitches. Thank you, Dinesh, again so very much. Thank you, Yogita. Yogita connects all of us together, all the members of ISG with the governing council of ISG, and also she looks after all the relay and putting all the questions to chat box. Thank you, Yogita, so very much. And before we end, let me invite you for another talk, which is coming up and becoming clinically relevant. Less is known about this talk, that is sarcopenia in chronic liver disease. This is, many people will think that this is not so important clinically, but most hepatologists would advise us that this is a topic which we must address to learn about it and maybe practice in our clinical practice, the meaning of sarcopenia and how it happens, what are the implications, and how you can prevent it. So next talk will be on sarcopenia and chronic liver disease, and this will be delivered by a very, very eminent speaker, Dr. Anil Chand Anand, and he is very well known. So we look forward to hear from him on sarcopenia and chronic liver disease on next Sunday, that is 28th of June, 12 to 1, our usual time for masterclass. And with this, we log off, and we see you on next week on Sunday 12 to 1. Till then, bye-bye. And
Thank you.
Thank you, Dr. Srivastava. Thank
have a
you,
nice Sunday.
Dr. Jha and Dr.
Bye bye, everyone.
Bye-bye.
Thank you so much.